something that Trevor and I noticed was around kind of this tension between like data intake and privacy, because this privacy creates information silos. So obviously when you're thinking about healthcare information, it's highly sensitive, particularly when you get to kids, it's even more sensitive. But to train and to like make the user experience a little bit more functional and fun and easier, you have to share information across providers and institutions. But there's a lot of legal reasons why we want to make sure that as that information is being shared, it's not being misused or mismanaged. So I think that was kind of a big learning point for us, is around why these things exist today and like where we can potentially use technology to lubricate some of these barriers.
Hello and welcome to Informatics in the Realm, the podcast designed so that everyone can become a part of the biomedical informatics dialogue, which is where the action's happening. I'm Kevin Johnson, a physician and informatics researcher at the University of Pennsylvania and at KB Johnson, MD on Twitter. I'm joined today by a new guest host, Stacey Iannone.
Hi, everyone.
Yeah, Dr. Stacey Iannone.
Thank you so much for that wonderful introduction. My name is Dr. Stacey Iannone. I'm the project manager for Dr. Johnson's lab. I have expertise in clinical research in a multitude of disciplines, and I'm so excited that I got to share my expertise and experiences with all of you. So on today's episode, we had a few special guests, Trevor Martinez and Pavan Patel, who are both master's students exploring technology in healthcare. Trevor is pursuing a master's degree in bioengineering, and Pavan is pursuing an MBA at the Wharton School and an MA in international studies at the Lauder Institute. These two are actually Dr. Johnson's students, and together they completed and together they completed a research project identifying pain points in the primary healthcare system and determining ways for technology to solve these issues in the years to come. So their work this semester has been remarkable and contributes to much of the conversation surrounding the integration of AI in medicine. So I thought that I'd share it with all of you. So,
thank you, Stacey, for convincing me that this would be a great podcast. I'm very excited about hearing about it. We also have Dr. Ross Capel chiming in. Dr. Capel is a professor of medicine and sociology at the University of Pennsylvania and a senior fellow at Penn's Institute for Biomedical Informatics. Dr. Capel has a ton of knowledge surrounding healthcare information technology. He's been around a long time, and we love that he was able to jump on this podcast to share his insight and to brainstorm ideas with these students. Trevor and Pavan have uncovered so much about how we can improve primary healthcare, not just for patients, but also for clinicians, and in a really short time. So without further ado, let's get into it. Well, hello, everybody, and welcome to Informatics in the Realm, the podcast that's designed to talk about informatics issues for my mom and others like her who are sitting at the kitchen table wondering what the heck all this stuff is about. I'm Kevin Johnson. You all know who I am. I have a great co-host today, Stacey, who goes by Iannone, even though it's spelled Iannone. Stacey, say hello.
Hi, everyone. Excited to be here today.
And who are you?
My name is Stacey Iannone, and I am a project manager for Dr. Johnson. And this is my first podcast ever, so I'm really looking forward to this being my first time and the content that's shared today. So thank you for having me.
So you're kind of a podcast virgin?
I am. And I was kind of looking into, podcast etiquette, and it seems like there's no cut and dry way of behaving a podcast. So I'm looking forward to just being real. So be ready.
There you go. Well, speaking of real, we have some real talented others on this podcast, beginning with Trevor Martinez. Trevor, say hi and tell people who you are.
Hi, everyone. My name is Trevor Martinez. I am a master's student at the University of Pennsylvania. I am studying bioengineering, and I've had the opportunity to work with Dr. Johnson this past semester, as well as Pavan. And I am also, like Stacey, this is my first time on a podcast, so I'm very, very excited and looking forward to sharing all Pavan and I have got to work on.
Woohoo! Pavan, who are you? And tell everybody who you are.
Hey guys, thanks for having me on, Dr. Johnson, and it's been a pleasure working with Trevor and the team on some work in primary care. My background is mostly in finance, but I'm also similarly a graduate student here and had the pleasure of taking Dr. Johnson's course actually here and at Penn, and also my first time on a podcast. So very exciting for all of us.
Wow. Well, just imagine that we're all sitting around a table. That's why it's called Informatics in the Round, and that we are interrupting each other and just sharing ideas and thoughts. And as I mentioned to you guys, one of the really interesting things that's going to happen today is going to be like our Mr. Rogers moment, where we're going to have someone knock on the door and enter our neighborhood in the middle of the podcast, which will be great. So I want to just tee this off by talking a little bit about why this project even came up, which was, we know that a lot's happening in healthcare right now, and we all have experiences that we'll get to share. And one of the themes for this year in the podcast is about AI in medicine. And we're also quite aware of the fact that you could argue that many of us have been in practices, we're seeing physicians and nurse practitioners who aren't ready for what's about to happen to them. Rooms that are not necessarily well configured, knowledge that they may or may not have, workflows that may or may not be well integratable with what we might see in AI. And we're going to talk about that a lot. But both Pavan and Trevor had a chance this year to think about this issue and spend some really dedicated time looking at what healthcare needs to do, both in terms of structural change, but also in terms of procedural change. And I just loved to hear from them, and I thought it would be great to have a conversation. We so rarely get a chance to hear from sort of the group of people who are going to make those changes by creating companies or being a part of major other groups that will be highly funded to do this work, that this is really, to me, a wonderful opportunity to learn and to see what the future holds. So thank you both for coming on today.
Yeah, thank you. Excited to be here.
Great.
Same.
So let me just tee this off by saying, just for the people who have not heard anything about this project, tell them what you did and why you did it. And then let's talk about the results after that.
So I approached Dr. Johnson at the end of last semester after taking his course, looking for opportunities to do an independent study, sort of furthering on some of the ideas that were discussed around technology and healthcare. And one of the projects that he mentioned to me was this sort of imagination of what primary healthcare can look like in the future, a decade or so down the line. And so I was very interested by the project and the idea of thinking through it. And Dr. Johnson connected me with Pavan, and we sort of got to work thinking about how can technology be integrated into the primary care clinic to aid and augment providers, physicians, and sort of improve the experience for all the players.
Ding dong. Hey, look, we have a guest today. His name is Dr. Ross Capel. Ross, say hi to everybody.
Good morning.
Good morning. Good morning.
Good morning.
And Ross, who are you?
I'm originally a sociologist, but for the past 30 years or so, I've been pretending to be a professor of medical informatics. And I'm at University of Pennsylvania. And I write a lot about usability issues and problems with EHRs and the like.
That's like the nicest way you could have said everything that you've done, and of course, the most modest. I will make sure that in the liner notes we say quite a bit more about Ross, but in the interest of today, I'll just say that he's one of the foremost people thinking holistically about the way technology and healthcare need to interact. He was also one of the early adopters of Google Glass, and that might even come up in today's conversation. So I thought it would be terrific, and Ross got very, very, very last-minute request to join us. So thank you so much for pulling that off. I can't tell you how much I appreciate it. Okay, so Trevor gave us a great introduction to what he did. Pavan, anything you want to add to that?
I think the only thing I would want to add for the group broadly is the focus was on kind of outpatient for adults. And the reason we chose that is that we think of primary care as kind of the first line of defense for a lot of these things, for a lot of issues. And so if you can improve primary care, I think you get better outcomes, not only kind of at that first level, but also then second and third levels. And I think it was interesting because that's something I know that Dr. Johnson, you focus a lot on, is thinking about like patient population health, particularly for folks who are kind of underserved or not typically involved in the healthcare system. And so I thought kind of those are the only other 2 points I would add, is there was a focus on primary care and a focus on folks who may not have access to healthcare otherwise.
Yeah, thanks. I'm really curious though. You've obviously had a great lived experience, and you've been a part of this project. And just for Ross to hear, one of the things they did was both visit some clinics as well as read and learn about the state of primary care medicine in this country. So I'm curious if you guys could summarize what you picked up. What was maybe good, and what would you love to see fixed based on what you saw or what you've learned?
Yeah, I'll let Trevor kick that off because I think he had the chance to visit the clinic.
Sure. Yeah. So I had a couple experiences visiting clinics over the semester. The first was just visiting my own primary care provider back home in Maryland. And that was an interesting experience because I technically should not have been allowed to get that appointment because I am 23. And so I'm now too old to be seeing my pediatrician. So I haven't phased out to an adult primary care provider yet. So it was funny. I was scheduling the appointment right around my birthday after we had started the project. And Dr. Johnson, you had mentioned that it would be a good way to sort of kick things off, just go get a doctor's appointment. And I was due for a yearly checkup anyway. And so it was funny when I went to the appointment, I could hear my doctor and nurse outside chatting, like, how did he get in here? Like, he's so old. Like, that's not supposed to happen. And it was a week after my birthday, so I just turned 23. And so it was funny.
That's hysterical.
Yeah, my doctor coming in, she's like, so you shouldn't be here, but welcome. This will be your last appointment here. So that was funny. And then my other experience was I got to shadow Bassam from the lab during one of his visits to record an appointment over at the clinic at Penn Medicine, an internal medicine clinic there. And so that experience was interesting because I sort of got to see another side, which, having only been in a pediatric office throughout my life, I haven't witnessed, which was that vaccines are not offered in adult primary care offices. And so my experience growing up was I could always get, flu shots or any sort of immunizations I needed to right in the office. And that was done and I could move on. But for the particular experience I got to shadow, I was able to witness in real time that this provider wanted the patient to receive a couple different immunizations, but they were not able to receive them in the office, so they had to refer them to a local pharmacy. So that was an interesting added layer, just one initial insight I had upon my shadow experiences. But
I'm just curious, Stacy and Ross, have you experienced that?
No.
The siloing of information?
No, the siloing of the way care is delivered.
Sure. First of all, one doctor's office doesn't know what the other doctor's office has done. Even though I have Epic Share everywhere and everybody's on Epic, I often can't get information conveyed. And they say it should be available, but it's not. And then I'm told, we don't handle that. You should really see a dermatologist about that. So I've been in this biz a hell of a long time. But for the average patient, referral to another clinician is often overwhelming and very hard to arrange. And yet we do it all the time.
Well, and I'll add to that. When I first received a booster for the COVID vaccine, I was in my doctor's office and I said, "Oh, by the way, I'm here. Can I get the COVID booster?" And he's like, "We don't do the COVID booster, but CVS does it. They do other things." So I got the shingles vaccine from my doctor's office, but and I had the pneumococcal vaccine from them, but they didn't do the COVID vaccine. And he informed me that there are other vaccines, just as you noted, that they don't always do. It's actually easier to get appointments elsewhere. So they've told their patients to go there, which I have to say, I'm imagining the mother with a couple of children who've had a hard time getting to the office being told, okay, so from here, go to CVS and get this other shot. That's a giant access barrier. I'm not so sure I would do it. So,
and CVS will demand all kinds of information about insurance that your doctor already has, that woman you, in your example, may not have immediately available. And if she wants the kids to get vaccinated too, she's going to need their records, and she may not have those immediately available or whatever. And, for the Latino population of Philadelphia, at least, there's this air bridge between Philadelphia and Puerto Rico, and people get treated in the clinica for free in Puerto Rico. And then they come back here and the record availability is close to zilch. So we don't know for kids what they've been vaccinated for, when, and the like.
Amazing.
Yeah, one thing that I'll just add there is something that Trevor and I noticed was around kind of this tension between like data intake and privacy, because this privacy creates information silos. So obviously, when you think about healthcare information, it's highly sensitive. Particularly when you get to kids, it's even more sensitive. But to train and to like make the user experience a little bit more functional and fun and easier, you have to share information across providers and institutions. But there's a lot of legal reasons why we want to make sure that as that information is being shared, it's not being misused or mismanaged. And so I think that was kind of a big learning point for us, is around why these things exist today and like where we can potentially use technology to lubricate some of these barriers.
I think for me, there's been some aspects of my life where it's been pretty fortunate in terms of coming from, a smaller town in the Pocono. So it was like a one-stop shop. And then obstetrics, they really don't want to burden, the expecting mom. So it's kind of all encompassing. Even getting labs drawn, you can go right downstairs. But I do realize that one of my children has a severe allergy. And in order for them to kind of be waitlisted for a particular kind of treatment that could potentially cure her from her allergen, there's a 2-year wait list, and you have to trek into the city for one aspect of it and then eventually venture elsewhere. So just thinking
my gosh.
Yeah. So just thinking in terms of just, cost and parking at CHOP, and then having the expectation that the individual can drive elsewhere, to Glen Mills. So that definitely is where I see frustration, just thinking a little harder in terms of what I'm going to be experiencing as I wait these 2 years for my daughter to be able to potentially be cured of, something that has an anaphylactic type response. So,
jeez. So did you guys, Trevor and Pavan, was that the worst of what you experienced?
There's a couple other points. I think the other point that we noticed was around kind of this, people get really excited about technology, integrating technology. AI particularly is a big buzzword, but there's this fear from the providers of like a loss of like human touch. And so if you think about, over mechanizing the process where you kind of cut doctors and nurses out of it. And I think there's particularly this fear maybe from some radiologists and other folks who just at a higher risk with technology. And so when we had a chance to talk to some doctors and nurses, they talked about this excitement for integrating with technology, but also this a little bit of trepidation around, as we do that, we should be careful about ensuring that kind of the doctor or the nurse or whoever is providing the care is actually at the center of the care. Because at the end of the day, it's people taking care of people as opposed to machines taking care of people. And so you want that to augment that experience as opposed to replace it.
I definitely echo those sentiments. I would say sort of more along the lines of what Stacey was saying. A couple of interviews that I was able to conduct with family friends of mine who are both nurses, one of whom is a nurse practitioner actually in the same pediatric clinic that I grew up going to. One of the issues she was talking about sort of with referrals and getting care specifically for children was she was talking about different templates and having to fill out different templates and how much that bogs down a nurse's time, and then specifically around mental health. If there are any sort of mental health or behavioral concerns for children, it's very, from the way she conveyed it, it's very particular and specific, the way you need to write those reports in order to get insurance coverage. And they're very heavily scrutinized. And that's just something that in the standard workflow of a day, a nurse is not going to be able, or a provider will not be able to do. And so, it could be, it's a really unfortunate situation where there could be very legitimate concern for a child's mental health, but they might not necessarily be able to get that care. So that, I would say, was probably one of the most alarming sort of pieces of information I was able to learn.
Yeah, Ross, you were nodding up and down.
Yeah, I wanted to raise the issue of MedRec across various silos. I know my own experience has been, I think psychotic is the only word. So years ago, I started on PPIs, proton pump inhibitors, to deal with acid reflux. And they were prescription, then they became over the counter, then they became lower. Then I tried H2 blockers. And even though I am professor of medical informatics, I cannot get my doctors to get my meds listed properly. I tell the doctor, the nurse, I haven't been on that drug for 20 years. And she says, well, I'll mark it inactive. And I say, okay, but if I end up at an ED, are they going to, know the subtleties of your record? So according to my records, I have been simultaneously on PPIs, about 14 of them, since 1985.
Jeez.
I have absorbed no food. I weigh nothing. I'm long dead. And I can't get it fixed. And this is what I do for a living. And my doctors read my JAMA articles and that, and they know who I am. And yet I can't get it fixed. This is me. For the average, 70-year-old trying to fix up their meds. And we know that the average old person is on like 12 meds, not including the uncounted over-the-counter and herbal supplements, which sometimes interact significantly, as Kevin will tell you. It's chaos. And it's a classic example of the lack of coordination among various doctors, offices and hospitals. So I'm writing a fun article entitled My 26 Patient Portals. I've counted them. They bear little relationship to each other. They sort of got my name, my age, and my gender. And after that, it's total chaos. And that really affects care, especially, for a complicated child, it's dramatic, as Kevin could. And just for anybody over the age of 60, it's probably serious.
Hey, for me, I couldn't remember the passwords to 4 patient portals, let alone 26.
What do you? I guess I just have a question for both of you guys, or for the team here. I think everyone knows that this is an issue, right? Like that people have different portals. There's a lot of information silos. Trevor and I have done a lot of work on understanding that. But I'm curious, given you guys also study this, like, what is the main barrier to entry to integrate this system? Is like the data privacy laws, so forcefully it has to be? Or I guess I'm just curious of, like, if everyone knows there's a problem, why is it still a problem?
Well, I'll start this one, but I'd love to hear what other people think. First of all, I have to give you the anecdote, which is the first time I realized the state of our world was this set of ads that, and I forget who it was, but they had a famous person going up to a ticket counter and, talking to the person who's just like, totally fanning out over them. And then at the end, they would say, "Oh, may I have your ID, please?" And I'd be like, seriously? And you realize that they were making a joke, but it's true, right? People know you, and then they ask for an ID, and it's like, why are you doing that? I think part of this has become either hard-coded technology, which says, until you do this thing, I can't do this other thing, or in some cases worse, which is I think we've given up. And, could we get from 26 to 4 portals? In fact, there might be duplicate information. We haven't talked about it, but Ross may say 5 of my portals do actually connect. And so I only have to check 1.
More than 5.
Yeah. So I think part of the problem is how we present the issue, but the issue is still there, which is if you're a patient and you don't understand it, you don't know exactly what's missing, what you should log into. And years ago, studies showed that about 70 to 80% of patients believed that we had complete data sharing, when in fact we never had any, because they thought that all of these systems that were asking questions must be doing so and sharing them with other systems, but that really wasn't the case. Now it's even worse, because now it's inconsistently inconsistent. So sometimes it happens, sometimes it doesn't. Sometimes it's a connection that you believe to be present isn't quite syncing, as we were talking about earlier, even on this call. Do I get that right, Stacy and Ross? Is that what you're experiencing as well?
Yeah, for sure. I think initially the plan was interoperability, communicating with other, systems to make there be a more streamlined flow of information. But what I'm finding is that I know that there's been a huge decline in, the numbers of people wanting to go into the healthcare system. And I think that they're seeing that even though this could be potentially improvement, I think they're seeing it as more work, more training, more things that are taking them away from patient care and not looking at the far benefit on this could potentially decrease, their fatigue, decrease wait times, improve patient and physician interaction. So I think being in the now, people are just so inundated with stress that they're not looking into the future and the possibilities of how this can improve everyone's, I think, well-being overall.
Yeah, yeah.
Amen, Stacy. And, I published something with the folks at Harvard, but it was a Penn project in part. And we looked at how medications are listed in various EHRs across hospital systems. And some are listed, so you get a warning for warfarin, but you don't for Coumadin. Mm-hmm. But the patient is already on it or allergic.
Which are the same medications, right?
Yeah, sorry. And you get a warning if the drug is ordered through practice favorites, but you don't if you order it from the drug dictionary in the hospital. And then we found drugs that were listed as blah, 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 but don't order this without contacting Bob in renal monitoring. And try doing a search for that drug.
Yeah, really.
Don't know that it includes. And some hospitals had the drug part generic and then brand name, or it would include as part of the name the dose or the route, and others did not. And that sounds, esoteric, but if you're a young doctor or even an experienced doctor looking for your drug for your patient, knowing the intricacies of how 5 hospital systems kept their meds listed means you're going to miss something, or you're going to miss a drug-drug interaction, or you're not going to be able to order the drug that you want for your patient because of the idiosyncratic way they're listed across 5 institutions.
Well, this is a fantastic segue, because one of the things that Trevor and Pavan have shared with me is the knowledge graph that has to do with information flow. Would you guys mind showing that and walking through it for us?
Sure.
You're going to love this, Ross.
So a little context here. As we went through kind of some of the both the clinical visits and also our research with individuals, it became abundantly apparent that there was a lot of information silos and potentially for a good reason, and then maybe not. And so what we wanted to do first was, Trevor did a great job of mapping this out, and I'll let him take it from there. But we have some key points where we saw some linchpins to potentially integrate technology to help folks talk across systems.
I have to say, I love that line. Potentially a good reason, but maybe not.
Yeah, because I think that here's the truth. I think that a lot of times, if everyone looks at this and says, this doesn't make sense, right? There may be some real reason why it doesn't make sense. And then others why we have to get it fixed. And I think that what we wanted to show is that, yes, that's true that partially some of this information has to be separate for either privacy reasons, legal reasons, business reasons. But a lot of this information does not have to be inherently separate.
So when I was building this out, I was kind of thinking about primary care from a couple different angles. And initially it was really just, okay, let me write down, sort of the different players that Pavan and I have come across in our research and then our experiences throughout the semester. And then like the important pieces of information in everything we've seen. So things, like appointment scheduling, immunizations, those types of things, referrals, and then how all of those connect to EHR. And so sort of seeing who in the sort of, line of care, which providers are accessing these different pieces of information, who has access to them versus who doesn't. And then I was sort of thinking, along the lines with different initiatives that came up during class, your class, Dr. Johnson, ideas of like, precision medicine initiatives and those sort of things, and how that would be integrated. So sort of mapping, some of the more particular information that is relevant to patients, and is that something that healthcare providers have access to? So we have these couple big circles, and the blue circle is supposed to be encapsulating all of the information that a doctor sort of has immediate access to based on, sort of what Pavan and I experienced and were able to research over the semester. And then the light green circles are the information the patient holds or has access to. And there's, really just the sort of disjoint was, and this is something that I sort of pondered based off of a couple of comments you had, Dr. Johnson, and then just some of the other things we were able to witness was the disconnect between, all of the information that really informs a patient's health, and health being that sort of definition of not just, am I feeling healthy or am I sick, but, health being, are they able to really be, resilient in their life and sort of achieve what they want to achieve, and how, pieces of information like living situation or quality, do those get integrated into EHR systems at all? How much is that communicated to doctors? And so that was one of the sort of just different, two different silos we saw between knowledge of a doctor, a provider, and then a patient.
Well, let me ask a couple of questions. So first, I look at the receptionist in your knowledge graph, and your knowledge graph has information about what pharmacists, doctors, nurses, receptionists, patients, and EHR systems may have as connections. I note that a receptionist is in charge of, or at least has knowledge about the specialists, about appointment scheduling, and about referrals. Not so much, though, any information about the patient's living situation. I would think that's a problem. Do you guys agree with me?
Yeah, I think one quick thing that I would add here is to underscore what Trevor said about the daily quality of life and the living situation. I think there's a big material finding that he kind of that Trevor was able to uncover. And I had a chance yesterday to attend a talk with the Surgeon General, Dr. Vivek Murthy, and he talks about loneliness and how loneliness, outside of just personal benefits, has serious actual medical impacts on like chance for anxiety, depression,
right,
obesity,
right,
etc. And so, yeah, we do. I think that it would make sense that information is actually included in part of the care.
Yeah, I mean, for me, and again, I'll stop talking here, but I look at that and I think if I was a patient who had a challenging living situation and people were sort of calling me, which I get occasionally, about appointments that just couldn't possibly work, or worse, saying things about where I could go to have my care, knowing full well that my living situation would make that impenetrable or intractable. It would seem like that would be information you'd almost want to alert and say, please don't send this patient to a different state. They will have a difficult time getting that appointment or getting to that appointment. What are you all seeing in here that you think is interesting?
I think that's a hell of a burden to put on the receptionist.
What, knowing about the living situation?
Yeah, I think that's not going to be well handled. However, that would be an ideal role for AI to be able to insert that into the chart and into information. assuming the AI had it. I do want to make two modifications to this chart, which I love. First of all, it's more than one EHR. So it should be EHR systems or EHR's system. And the other, I think you're going to get a kick out of, and that is, I would love to have a degree of reliability added to almost all of these pieces of information. So, if you ask people about their allergies, you get total crap. I've been allergic to penicillin since 1935. Excuse me, lady, they didn't have penicillin in 1935. Well, my mother told me I had a reaction. There's all kinds of lousy and confused information that patients have and that are in the record. And I would love, as an intellectual, just don't try to do it now, but as a thought, let's apply a measure of reliability or validity to all of these. Because the amount of misinformation and confused information, especially among, God forbid, patients, is non-trivial.
It's almost like every box has a color attached to it. They're all yellow here, but what you're suggesting would be there should be something that reflects the degree of confidence we should have in what we receive from that box. Yeah, that's great.
I might also like to add that I would love to see how MAs, medical assistants, would play in this. From an obstetrics end, those were the individuals that I actually communicated with most. And they incorrectly documented the fact that I had a bee sting allergen. So that was actually incorrectly captured. And then I didn't know until the doctor kind of conveyed that maybe months later. And they said, I saw that you had a history of bee sting. So I think depending on, the type of medical doctors that you see, MAs do play a pivotal role in capturing the data, speaking with you. There's been times where they've shared a lot of private information. A lot of times there's some socioeconomic issues amongst them and possibly the patient that they kind of bond with. And a lot of times they'll feel more compelled and more of a safe space to share, because you'll a lot of times document your income or any of those social challenges via the portal. And a lot of times people don't want to do it there. They don't want to be stigmatized. They don't want, their children potentially be taken away. And I think that MAs sometimes are the bridge or kind of the barriers to kind of medical information, but I think that they are a key component to the medical system as well.
Well, that's really, really incredible. I hadn't thought about any of that.
I love that insight. Thank you.
So, you guys saw a lot of this. You had a chance to put together this knowledge graph. And then what I loved was you really started to think about this question about how can tech aid primary care providers? How can it help us to deal with some of the workflow challenges? Talk to us a little bit about maybe that.
So sort of along the lines of what Ross was saying, I think there is a big opportunity for AI to be able to summarize a lot of this, complex information about patients, because it's just too much for a provider to do themselves. And so some of the information around a patient's daily life, living quality, patient history, past illnesses, reactions. I think the opportunity for summarization is sort of the most direct opportunity that Pavan and I discussed and sort of identified in the immediate to near future.
That's a great one. I was just going to say that one sounds like it could start to address the issue that Ross came up with, which is the burden of giving receptionists, for example, additional information. If we could summarize, perhaps that would help.
Yeah, I think so. I previously worked at a company called Hazel Health. They provide healthcare to kids through schools, and went into work and visited a lot of school systems to see school nurses. And I think the key, at least at something we saw, and also Trevor and I noticed in our research, is if we're going to integrate technology into the healthcare system, it has to be viewed as something that's going to take away work, as opposed to going to be another tool that they have to enter in information into. disrupt their workflow. And so we mentioned that as a potential challenge, because if it's viewed as, it could be the best tool in the world and it could theoretically save them a lot of time. But if these folks are incredibly busy, they have a lot of people that they need to take care of. And if it's viewed as another kind of tech initiative from a bunch of engineers or business folks that don't really understand their life.
I am so glad you brought that up. Ross, I wanted to hear from you about this because Ross and I met at many times in our career, but one particular time was when he visited Vanderbilt, extolling the virtues of Google Glass, which was touted to save time. And yet we don't use it. Is that a good example?
Yeah. I was asked by Google to bring Google Glass to medicine. That's the context. And it did some wonderful things, but most of those things were accomplishable, if that's a word, by just having a camera on top of the operating theater, or by dictaphones or whatever. But there were some uses. So one was in pediatrics, and Rich Schiffman, who undoubtedly Kevin knows, he wanted to use it at Yale for early doctor training in pediatrics, because the way it worked, the supervising doctor, Rich, could talk to the young doctor using bone conduction of Google Glass. So while the doctor was doing an interview with a kid, Rich could say to the young doctor, "You're going to ask when the pain started? Or what about the other arm?"
That literally is exactly the way Rich would say it, by the way, guys.
So, in other words, it had uses, but most of the time it was just lousy. It was superannuated by other things. Plus, it had such a bad reputation, and the term glass hole came around.
I forgot about that.
Yeah, you could walk into a bar, and using the camera, you could figure out everybody's name and relationship and stuff like that. And that's no way to meet people by finding out their average mean income or whatever, just by asking. But we wanted to use it for dictation also, because the doctor could dictate while looking at the patient and taking images of the patient, which for, let's say, dermatology would be invaluable. But the dictation didn't allow corrections, and some of the auto dictation, could not distinguish between ontology and oncology.
It's a big difference.
And that gets really stupid.
Yep. So what else did you find, guys? What else ideas did you have?
Yeah, I could kick a quick one off and then Trevor, you hop in there. So Trevor mentioned the mental health forms, right? And how there's so I think it's just taking a step back. Let's think about what AI is actually good at and what it's not good at, right? AI is good when it has a lot of information that can be fed to it. It can be corrected, right? So it has to be told that this is good, this is bad, right? And it's generally highly scalable with the exception of some increased compute power requirements. But things like free response intake forms are perfect for this, because you have currently this already exists in sense of like, we have LLM models are a huge thing, right? Large language learning models. And so we thought about what is the issue with these intake forms is that there are a bunch of different fields and bubbles, and doctors, nurses, MAs, other folks have to put this in. And it's not entirely clear where, what field maps to what field. Now, if you had a free response intake form that you can get in from patients, potentially they could provide more information, and the strain of reducing that free response intake into fields that can be codified and put into EHR systems that are somewhat standardized can be put on the AI. And so there's obviously potential challenges with that, with like type 1 and type 2 errors, but I think that's kind of another initial thought.
Yeah, the free response, I think, with templates, that was a big pain point that came up in the interviews I was able to conduct, was that you can have a standardized template, but it's not really standardized because of the individuality of patients. It's, you could have the quote unquote perfect template, so to speak, but you're going to have workarounds or sort of, individual just details that are pertinent only to specific patients. Another sort of area that we were thinking about from the patient perspective is summarization of appointments so that patients can have information from their appointment that is relevant and valuable for them to follow up on, just so that, because I think, there's the issue of whether or not patients are in a place where follow-up care is accessible or barriers for that. But then also there's just communication issues of making sure a patient knows everything they need to know and do. And so, it was interesting when I got to shadow over at the clinic here at Penn Medicine, and we had Bassam and I performed a quick survey afterwards, just asking about the experience of having their appointment recorded. And I think having some sort of process in between the end of an appointment and a patient leaving. And I know a lot of times you'll check in with the receptionist afterwards, schedule a follow-up potentially. But I've also had experiences personally where I just walk out of a clinic and it feels kind of weird. Like, am I supposed to check with someone about something? And so I think there's a nice sort of finality if you could have some sort of automated system that's like, all right, here's a piece of paper, or maybe an email report of just these are all the sort of bits of information, exams that were performed, whatever. These are the actions a patient needs to take to follow up on afterwards to address this concern or to, keep on a good track if they're healthy.
Just legally, Trevor, you're supposed to get a visit summary. And by legally, I mean the doctor's office could be pinged significantly by CMS if they fail that role.
Wow, I was not aware.
That's why his pediatrician was freaking out. It's like, he's too old. He knows too much.
Exactly.
I looked at your slide deck. I love slide 15, which is generalized methods to break down silos. I think it's really an excellent slide.
Would you guys say what that slide is about?
Yeah. So this was just an article I came across, and it was generalized methods to break down silos. So not even methods that necessarily leverage technology or different tools, but some procedural processes that teams can take part in, or structural. And I think some of these items are things that can be greatly aided by technology, things like making information visible, aligning teams under common goals. You can make potentially dashboards or interfaces that can help sort of create cohesive teams. But these are just some different methods to sort of break down the silos that present in healthcare.
What I love about this slide, number one, let's thank Rhonda Stewart, because it's her piece called 5 Tactics to Break Down Silos and Support Cross-Functional Collaboration, that appeared in the Virginia Mason Institute's site. But what I love about it is what you were just saying, Trevor. It sounds like we could almost overlay this with technology that either is in place or should be built, huh?
Mm-hmm. Yes.
Yeah, no, technology really could help on this. And there's another aspect of this that make information visible. As a friendly amendment to that, I wanted to also show information that we're clearly missing. So, if you have this whole thing and there's a lab report or an X-ray that makes total sense to be here, and we have reason to believe was done, so where the heck is it? So making information visible would also make missing information more obvious.
Oh, that's brilliant.
Another thing that we saw here, I think, was also kind of the subtraction of information, that we're talking a lot about kind of adding either technology or pieces, which we saw a lot of. But one thing that Trevor and I noticed was there's also a lot of value in maybe removing some processes or deleting some information, because there's a lot of duplicate information out there. And that could potentially also help with kind of reducing burnout and whatnot. It's not just, we want to make sure that we're reducing the workload on the providers.
So I hear something from you guys that I'm wondering if a lot of our listeners will understand. Stacy, does it make sense to you, this idea of subtracting information?
Yes.
What do you think it means? Just I want to make sure I understand it.
So as Pavan mentioned, I think just removing duplicate information a lot of times, even from like a research perspective, seeing from a research coordinator perspective, just seeing information that, as Dr. Capel also mentioned, that's incorrect, that has kind of been copy and pasted moving forward and incorrectly capturing information that has already been resolved or no longer applicable, which can be detrimental to current care. So I think removing the duplication piece, I think would be important. Just kind of looking at the chart there, I wouldn't kind of remove like the bubbles that I see, but from an internal perspective, like duplicate information, I think would be essential in improving care.
Good point. And remember, when you leave 600 pages of legible gibberish in a patient record, most recent physician has to sort of spelunk through that to find the relevant information. And if you included labs from a week ago and, it doesn't have a big sign saying, for gosh sakes, find the recent labs. That's not only annoying, that's potentially lethal.
I agree. Great observation.
Christine Sinsky has a case of a patient who was admitted from a car accident, comatose. And until the moment she walked out of the hospital, the patient, 2 weeks later, her record read that she was comatose and the like. And apparently, as approaching the exit door of the hospital, she had this miraculous recovery, which was not indicated over the 2 weeks of her stay. And that's just copy and paste, ad infinitum with not a good update. And clearly something was happening in those 2 weeks because she walked out. And yet the chart doesn't show that clearly.
Yeah, no, that's a great example. And we've all seen one of the most obvious examples of the missing information piece, Ross, is something you brought up, which is patient goes to the emergency department, has a drug allergy. Everybody decides to stop the medication. And 2 months later, CVS sends a refill request. And that's one of the classic examples that's really, really hard to fix. And it relates to many of the boxes on this slide, doesn't it? Because it's all about who are the different teams and what are their goals. And it's making information visible and breaking down geographical barriers, among other things. There's probably others. So it's a great slide.
I love the making information visible. So, for instance, your cardiologist wants to lower your dose of warfarin, Coumadin, anticoagulant. And so she lowers it from, 4 milligrams to 2 milligrams and some complex schedule. But what happens is the patient receives in the mail both the 4 milligrams and now the new 2 milligrams. And not every patient is a cardiologist. And basically you're giving them good reason to hemorrhage to death. So part of the thing is there's not a good feedback mechanism to the physician about what drugs have been cumulatively, if I can add a word here, sent to the patient with shitty instructions.
And if I could also share, I remember I had a procedure done at Penn, and I was discharged with, a narcotic. And then I was also notified by CVS that prescription was filled. So even thinking, that there could potentially be a very fatal, lethal ramifications long-term, in terms of fatal and addiction, right? I think that not having that communication, I could have easily have gotten what I was released with and then also filled that prescription. And that could have just been, a bottleneck of very challenging life experiences.
Yes. I know we've run pretty long, and I want to make sure that I give you guys a chance to give us any final thoughts. But this, we'll make sure that we put a lot of this into the notes, and maybe it's time for you guys to put together a piece for medRxiv describing some of what you found so that I can help all of our listeners find this really great work. But let me ask one final question, which is, if you could imagine fast forwarding into a healthcare environment 30 years from now, that's too far, 10 years from now, what do you expect to see different now that we've got all this great technology? Like, what's the thing you expect to see that you're going to say, yeah, we thought of that?
Pavan, do you wanna start off?
Yeah.
Or?
And I should say
sure.
for the listeners, this is the hallmark of really great, well-trained students. Total silence followed by the handoff.
Yeah, I'm happy to take it.
Performed.
Yeah, exactly.
If I may.
Trevor, do you mind pulling the screen down just so I think I'm having trouble seeing some folks? Yeah. Okay, perfect.
Another stalling tactic. Very good.
Yeah, exactly. And here's the third. Just to repeat the question, he said, in 30 years, how do we think that technology is going to impact healthcare, right? I think there's three things. One, in the short term, one of the things we found was around, like, what can we actually do today with the technology and the healthcare systems we have today? So that's kind of some of this patient summarization tools. And the reason we think that's interesting is because, one, is really high impact. We talked a lot about confusion and lack of visibility into the healthcare system and also an abundance of information. We already have all the information today. There's limited privacy risk because it's not going to be another person reviewing it, right? And third, we have these LLM models. And so that we look at as maybe potentially a short-term piece. I think medium to long-term, what we get really excited about with AI and with technology in general, but AI specifically in machine learning, is around this ability to personalize care. So every individual, right, has, unique living circumstances, unique diet, unique exercise, et cetera. And we're not able to convey that in part because we don't provide that information. But even if we did, right, provide all the information, if there was a world that you could do that, a single human doctor can't process all of that information and provide a salient recommendation. And so we think kind of medium to long term, as we think about, this is very long term, we have genetics mapped out, et cetera. If we can preemptively screen populations based on living conditions and healthcare situations to say, hey, look, you're actually at risk of this disease in the future. And so let's get you into primary care today to think about lowering X, Y, Z factors. And so now we're not actually, when we think about healthcare, we're actually caring for the patient prior to they have a problem. It's proactive instead of reactive. And so I would say that those are the 2 points. Today, what can we do with our systems and processes that we have around LLM models, which will kind of still do that Band-Aid effect? And then long term, as we think about, can we switch it from a reactive model of healthcare to a proactive one where we screen and provide healthcare to patients prior to them needing it?
Oh, that's fantastic. Trevor, anything you'd add?
Yeah, I would agree. I would say, from my perspective, I think the idea of tools like AI being used for screening is sort of the dream. The precision medicine initiative, being able to integrate a lot of data about patients. I mean, there's so many wearable sensors. There's so much information that even a Fitbit or an Apple Watch that you could integrate. There's genomic data. There's a lot that could be done. The skeptical side of me, based off the experiences of the semester and sort of the engineering part of my brain, is more sort of focused practically on, I think that's a great dream and something that's achievable, but systematically the structures of healthcare are not supporting the providers really. So my hope would be that's what technology and AI could do. And if that was, what was implemented, I'd be like, oh, that's really cool, of streamlining communication across providers, across patients, making data that it already exists, not even, more granular data like genomes or more individual biochemical markers, just the information that exists now. How can we make that more interoperable, more accessible, more centralized for patients and providers so that everyone's on some sort of common footing in a way that still protects privacy, is within all the regulatory statutes around healthcare. So yeah, I sort of have, I would say, maybe a little less aspirational vision, but I think if you can create the foundation of having a system that can more readily.
Trevor,
feeling.
Ross is in love with you now. I just want to let you know that.
I think, you know, I would just personally think it would be wiser to sort of get what we're doing today right before trying to build out to sort of the idea of pre-screening patients or subpopulations for different risks. Though I know it's a balance and improvement's an incremental thing, and it goes up and down, and then you have big jumps. But that would be my sort of vision 10 years down the line.
That's amazing. So Ross, what final comments do you want to make? How did they do?
Oh, they did great. I love the graph and the results showing the connections and worse, the lack of connections, or the frazzles connections. How's that for a term? But I want to end on an optimistic note about the role of computers and AI in addressing some of these silos. You know, AI is great at pulling together all kinds of information. It may bollocks it up, it may confuse it, but it's magically wonderful in pulling stuff together. And a lot of the gaps that you've pointed out, or silos, are addressable with good AI that could pull together this information, and not only pull it together, but also show, as I argued earlier, the gaps. You know, so where the hell is the 1999 health report on this guy when he first had oncologic issues? You know, somebody identified that. He didn't look up Google and decide that he had cancer and submit a slide to a pathologist by himself. Identifying the gaps and filling them is an ideal way. And your work in identifying the gaps in the silo is instrumental in building that back up.
Well, that is a great final comment, because I think that's a key point. And, you know, if I want to thank Trevor and Pavan for coming up with these great ideas, doing all this work this semester, I guess Stacy and Ross, I should give them an A. Okay. All right.
Great job. This is
right.
wonderful.
Thank you.
Well, thank you guys so much. And I am sure that there'll be some listener comments about this, and I'll make sure I share those while you guys are on vacation sipping pina coladas at some exotic location.
Sounds great.
Awesome.
All right.
Okay, great episode. I was, again, so excited that we were able to have so many guests, all thinking differently and creatively about how the exam room of the future needs to change to support the kinds of technology that we're going to have. Did you learn anything really pithy from this one, Stacy?
Absolutely. I learned the importance of communication amongst all individuals, even within the same clinic space. Sometimes miscommunication can definitely result in, some challenging circumstances. So it's great to have interoperability and also communication amongst the clinics and within other healthcare systems. So it's just great to see collaboration and communication work. And when there's deficits, kind of like the results of that. So it's awesome.
Yeah, and what I loved is that they started thinking about new technologies to improve communication. And I remember when they first told me that that was one of the themes of their work, I said, you have no idea how important that's going to be. So I was excited that they could come and share some of those ideas. And I look forward to the dozens of startups that are going to be created based on this podcast. I just want some royalties. I don't ask for much. So anyway, thanks for listening to this episode. To hear more about this episode or other episodes and our new releases, find us on social media at InfoInTheRND on Twitter, on Instagram, on Threads, and on TikTok. And if you have any questions or ideas for things you want to hear about for new episodes, please message us on any of those platforms or email us at informaticsintheround, no spaces, @gmail.com. That's informaticsintheround@gmail.com. See you later.
See you later.
Praying, but hurting like the devil, and keeping something that's broke and hoping that the other one folds. We're shaking our fists, ready to shoot. We think we can guess what the other will do. There's a good chance I'll crush you. You'll cut me to the bone. We'll cover it up. Or maybe we won't. You're too proud to ever give up. And I'm no quitter. So we're stuck in a game of rock, paper, scissors. Same room, but different places. Strangers with familiar faces. Now we're nothing but pictures and frames and silences waiting to break. We're shaking our fists, ready to shoot. We think we can guess what the other will do. There's a good chance I'll crush you. You'll cut me to the bone. We'll cover it up. Or maybe we won't. You're too proud to ever give up. And I'm no quitter. So we're stuck in a game of rock, paper, scissors. Stand to lose, so we play again. It's gonna kill us both, trying to win. We're shaking our fists, ready to shoot. We think we can guess what the other will do. There's a good chance I'll crush you. You'll cut me to the bone. We'll cover it up. Or maybe we won't. You're too proud to ever give up. And I'm no quitter. So we're stuck in a game of rock, paper, scissors.